Next talk is talk number 14, single-site review of spinal cord protection protocols, including the utilization of spinal drains versus medical management with branched endovascular aortic repair, by Drs. Lucas, Johnson, Reihis, Hora, Vandenhall, Bates, Sangos, and Kelly.
And this is a virtually recorded presentation. We'll have a live Q&A afterwards.
My name is Spencer Lucas. I'm a fourth-year medical student at the University of South Dakota, and I'll be presenting my work virtually titled Single-Site Review of Spinal Cord Protection Protocols, including the utilization of spinal drains versus medical management with branched endovascular aortic repair. Regarding disclosures, Dr. Kelly, my mentor, has an IP on the unitary device. Here's a little background for you guys. The incidence of SCIs following these types of repairs range between 5 all the way up to 31%. Now, preventative measures that have commonly been cited include procedural staging, preconditioning with prophylactic embolization of the lumbars, spinal drainage, and then giving medications such as steroids, vasopressors, acetazolamide. Also noteworthy, 30-day survivability drops from 92% all the way down to 36% following a patient's development of a permanent SCI. The incidence of spinal drain-associated neurodeficits, including SCIs, range from 1 to 2.5%. So that begs the question, can we improve the rate of SCIs and patient outcomes if we prioritize the medical management and fluid dynamics over reliance on spinal drains? So here is our protocol. Preoperatively, we gave prednisone. We had early infusion of fluids. We would only place drains if a patient was unstaged, urgent, or emergent. Intraoperatively, we gave acetazolamide prior to the exclusion of aneurysms, and we had tight hemodynamic parameters for our anesthesia colleagues to follow throughout the procedure. We also maintained a high urine output. Postoperatively, we kept the patient bed rest 24 to 48 hours post-op. We had neuro assessments every 1 hour. We continued to follow these hemodynamic parameters. We transfused if a patient had a hemoglobin below 10, and we relied heavily on fluids over vasopressors. If a patient developed neurorescue at any point during their postoperative period, we immediately placed a spinal drain and we drove systolic blood pressure above 180 with fluids and/or pressors. Regarding the methods of this research project, Sanford Health implemented this neuroprotective protocol back in November of 2019. Now, this project is a retrospective analysis of 174 patients that include before and after the protocol was initiated. The primary endpoint was the incidence of any SCI. The secondary endpoints included outcomes such as mortality, stroke, MI, and renal failure. After this was done, we performed a subset analysis for those patients that we deemed high risk for development of SCIs. That includes patients with Crawford extents 1 through 3 and 5, urgent or emergent repairs, and those presenting with renal failure. Regarding our results for the complete patient group, the post-protocol group was more likely to have experienced previous SCI if they presented with a prior repair, history of MI, COPD, or peripheral vascular disease. The post-protocol group also had 4 spinal drains placed preoperatively, and these were all placed for those patients that were unstaged or urgent repairs. The post-protocol group also had improved procedural metrics, including contrast, EBL, fluoro, and complete procedural time. Regarding the outcomes and complications of this complete patient group, the post-protocol group had 1-year mortality rate drop from 27% down to 9%. And the post-protocol group also had the incidence of renal failure drop from 14% down to 3%. Now, regarding the high-risk group, the post-protocol group had the incidence of any SCI drop from 17% to 0% with a p-value of 0.04. Now, speaking anecdotally about the patients that developed SCIs, 3 of the 4 patients were within the first 30 patients that we treated at Sanford Health. Subject 9 developed irreversible paraplegia on post-op day 6 due to a perinephric bleed, anemia, and hypotension. Subject 19 presented to an outside facility on post-op day 23 with a groin pseudoaneurysm, hypotension, and new onset paraplegia. Subject 24 presented to the ED on post-op day 272 with a GI bleed, hypotension, and this resulted in paraplegia. And lastly, subject 131 developed paraplegia on the evening of their procedure, and this was secondary to a spinal cord infarction that was seen on MRI. Now, Sanford Health has standardized this protocol, and we have seen improved mortality rates after this. Despite our limited spinal drain usage, we didn't notice a change in SCI rates in the complete group, but we did appreciate the incidence that decreased from 17% all the way down to 0% in those that were deemed high risk, which begs the question, does higher risk have more benefit from this standard protocol? A big point that we want to make is that MAP is a single variable in complex physiology. We have to include other variables such as cardiac output, systemic vascular resistance, and lastly, hemoglobin. MAP does not equal perfusion. And lastly, we did appreciate improved outcomes with increased experience throughout the study. Some limitations of our project. This is a single center with a single surgeon as primary. And we also want to note that Sanford Health has open ICUs versus the closed ICUs seen in other institutions. This led to improved communication between us and consultants. So future plans for us is to continue examining this proof of concept. We will expand to other centers, hopefully, and we will continue following these patients specifically annually for 5 years, and this will investigate the longer-term outcomes and the durability of this repair. I'd like to thank Dr. Pat Kelly. Without him, this work would not be feasible. I'd like to thank VESS for allowing me to present virtually. I'd like to thank Sanford USD Medical Center, which is our site, and Angela, which is our research lead, and Carrie Bates, who is our stats lead. Now, I will be tuning in for Zoom to answer any of your questions in a little bit, okay? Thank you.
Questions?
Hi, Greg McGee from Los Angeles. Thanks for bringing your presentation to our meeting. If I understood the data correctly, it sounded like there was a decrease in mortality and decrease in renal failure in the total group, but not a decrease in spinal cord ischemia among all comers. But then when you did the subset analysis is where you saw the decrease in spinal cord ischemia. So I guess, but it's also over over a period of time. So were there other changes in your operative techniques that may have explained some of those findings? Because it's hard to understand why mortality would change because of a spinal cord ischemia program if it didn't actually decrease spinal cord ischemia. And things like staging, of the repair, other adjunctive procedures, ways to decrease the time of the procedure, et cetera. There are other changes that may have accounted for some of these findings. Thank you.
Great question. So regarding the mortality benefit, we did see a significance in the complete group. We did not necessarily see a significance in the high-risk group. And I think that's just power. I think that's the sample size. We need to have more patients. Regarding your second question, what kind of procedural metrics, I don't necessarily know if we treat the high-risk patients any differently. If that's what you're kind of getting at, I mean, we saw procedural metrics significantly improve for both groups, to answer your question.
Microphone over here.
Hi, Christine O'Ryan from Ohio State. Very nicely presented. Congratulations. I think this is really important work, and I like the way that you guys are going with this, sort of less spinal drains, even though, we don't see too many complications, but when they are, they're certainly devastating. We have a similar protocol that we implemented for us, and my question for you is, I'd like to have no spinal drains if possible, and when you need them, immediate placement of the spinal drain, and that's really the crutch that we have been seeing. So could you just comment on who places your spinal drains, and is it easy for you to get them immediately, within 2 hours from the onset of paraplegia? Thanks.
It actually is. So who places the spinal drains? Our MDAs are in-house at Sanford 24/7. So they
Thank you very much.